Welcome to another episode of Medicine Simplified. In this video, we will know about Pott Puffy Tumor. It is a non-neoplastic complication of acute sinusitis. It is first described by Sir Percival Pott in 1760. Pott Puffy tumor (PPT) refers to edema of part or all of the forehead due to subperiosteal abscess associated with frontal bone osteomyelitis. Usually related to infective pathologies of frontal sinus, either direct or through hematogenic spread. Coming to the etiology, the most common cause of PPT is infection of frontal or ethmoidal sinuses. Untreated bacterial sinusitis can lead to severe complications such as PPT. Head trauma, particularly frontal bone fractures, is the second most common cause of PPT, which develops due to direct extension of wound infection. Less common cause of PPT reported in small numbers of cases include cranial surgery, dental infections, mastoiditis, cocaine abuse, malignancy, insect bite, and acupuncture. Most common infective agents are Streptococcus species, Haemophilus influenzae, Staphylococcus species, Klebsiella species. As you can see in this picture, there is a subperiosteal extracranial abscess. Sometimes it can be parameningeal extracerebral abscess also, caused due to frontal osteomyelitis. Coming to the pathophysiology, increased prominence of frontal scalp is a characteristic of PPT. That means swelling of frontal scalp region can be seen in PPT. Results of accumulation of subperiosteal abscess originating from underlying osteomyelitis of frontal bone. Most common mechanism of osteomyelitis development begins with either untreated or inadequately treated frontal sinusitis, mostly bacterial frontal sinusitis. Subsequent septic thrombophlebitis causes vascular compress and bone necrosis. As you can see in this picture, there is a frontal prominence. If left untreated, this condition can lead to severe intracranial complications, including epidural emphysema, subdural emphysema, meningitis, and venous thrombosis. These conditions are caused due to communication between the frontal sinus and dural venous plexus through the valvulus diploic veins of Galen, which can allow septic emboli to spread, leading to intracranial involvement. Coming to the evaluation, imaging should be performed as soon as PPT is suspected. Both CT and MRI can identify PPT, subperiosteal abscess, and intracranial fluid. CT is superior for assessing airborne interface and any frontal bone or skull base involvement, while MRI can provide more detailed imaging of soft tissue anomalies. Coming to the CT typically demonstrates an opacified frontal sinus, which can be seen in image with stranding and swelling of overlying scalp. Bone algorithm will often demonstrate a defect in anterior wall of sinus due to osteomyelitis. Coming to the MRI, subtle intracranial involvement is more easily seen at MR imaging. As you can see in this MR image, there is a frontal prominence and intracranial involvement of abscess. Preferred imaging modality for post-operative follow-ups. Coming to the laboratory evaluation, first we have to do complete blood count. Next, metabolic panel, erythrocyte sedimentation rate, and C-reactive protein. White blood cell counts and inflammatory markers may be normal in up to half of the patients with PPT. Coming to the treatment, rapid diagnosis and prompt treatment of PPT are essential to reduce the risk of severe neurological complications. Most effective management strategy for PPT involves combination of systemic antibiotic therapy, surgical abscess drainage, debridement of devitalized tissue, and restoration of frontal sinus outflow. Coming to the differential diagnosis, conditions that may mimic PPT include abscess of forehead, cellulitis of forehead, frontal hematoma with or without secondary infection, frontal sinus fracture, frontal bone fracture, lipoma, osteoma, epidermal inclusion cyst, hemangioma. If you like this video, please subscribe to our channel. Thank you.